Hello, welcome back. Now we're headed for Unit 3 on our Week 1 of our pharmacology class. This one is on drug action, pharmaceutic, pharmacokinetic, and pharmacodynamic phases of drug actions. So it's a lot to grasp when you're new to this, and hopefully we can get through it and make some sense of it. If you have some issues, be sure to read your references, and then if you need to, you can always email me, and I would be glad to help walk you through some of this, because it is a lot to take in. Pharmaceutic is, the first phase of that is the dissolution of it, the dissolving of the medicine. And then you have the disintegration, which is the breakdown before it's absorbed. This is why liquids are absorbed so much faster. Let's just go ahead and let's move on to, let's talk about the learning objectives before we get into all this hot and heavy stuff. We want to know the basic terms used in pharmacology so you can understand those when you hear them. We want to differentiate among therapeutic effect, the side effect, and toxic effect. We want to discuss the mechanisms of pharmacodynamics. We want to explain the relationship between the drug dosage and the drug response and what is happening there. And I want you to be able to calculate a therapeutic index and discuss drug safety. Just understand the calculation that takes place in a therapeutic index so you can relate that to the drug safety issues. So if you'll look at it in the pharmaceutic portion, which is part of your nursing process, you have to understand this, is that when you take a tablet, there's steps that have to be taken for that tablet to be able to be used by the body. 80% of the meds that you give to a patient are taken by the mouth. The GI tract then has to take these drugs, and they need to be to get that tablet to be absorbed in the body. It needs to be a solution, so it can be. So your solid tablet, as you can see there on your slide, you have a solid tablet, and then that form must disintegrate into smaller particles so it can be dissolved in a liquid, which then is your dissolution. The drug then will dissolve and then be absorbed within the GI tract. Any drug in a liquid form, like if you've got something that's already been, not tablet, it has been put in a solution, it's already in the state where it will be absorbed faster. Another thing to be aware of is that your tablets, they're not 100% drug. They have fillers and they have inert substances within them that help the drug be able to be utilized. For example, some of the stuff that's put in them to helps them have a shape or a size that they need to be done to be able to be swallowed or taken in and hold the drug together. Another thing is that the substances that they put in there may help enhance the absorption of the medication. For example, penicillin is very poorly absorbed through the GI tract. So penicillin tablets then also have potassium and sodium in it, which are readily transferable over the cell membranes, and so that helps bring the penicillin into the system and actually helps with the ability for the body to utilize it. In the pharmacokinetics, there's the three phases we talked about: disintegration, which is the breakdown of the tablet into the smaller pieces. There's the dissolution is the dissolving of the part of the medication that needs to be dissolved into the GI fluid, therefore it can be absorbed. And then there's also one more part, it's the rate limiting, and that's the time it takes for the drug to be disintegrated, then to be dissolved, and then to become available for the tissue to be able to be used. And that's all within then is the absorption that takes place. And during that, there's three processes that can actually help with our means for the absorption of the drugs. The first one then is passive, that it's listing there, it's showing you on your slide. And that's the actually passive movement across the membrane and into the cell of the medication. That occurs mostly by diffusion, which you probably learned about in your chemistry classes. It's where the particles actually move from a higher concentration to a lower concentration. Another means of movement is active absorption. Now for that to happen, it requires a carrier, such as like an enzyme or a protein, and that actually takes energy, and it moves the particles, the drug, through the membrane and into the cell. It's actually energy movement of that. Then you have your phagocytosis, which is actually where the cells carry the drug over across the membrane by engulfing the drug particles and then carrying it themselves into the cell. On your next slide there, it shows the distribution of the medication. This is a process by which the drug becomes available. There is the protein binding effect that happens. There's the blood flow, as the blood flows and brings it around. And then there's the body tissue availability, or the affinity of the drug to the tissue. Let's talk a little bit about the protein bounding drugs. That's primarily albumin, which is the protein that is in plasma. So many drugs that are bound by plasma in varying degrees, and there's charts, and there's one in your book that you can look at, and anything that is 61 to 89% protein bound, that's a very high protein bound drug. Then you have your 30 to 60%, and that's kind of moderately protein bound. Anything less than 30 is a low protein bound. Now what that means is that only the free drug that's floating around in the body is active. So, and only the free drugs can cause a pharmacological response. So you have all this free drug floating around in there, and then you have all these others are bound to proteins. Now as the free drug is released and decreases because of elimination, then more of the bound drugs can be released, and then it maintains a balance of this free and this bound drug. So it lengthens the length of time that the drug is there and can be used. The problem is when a patient is receiving two highly bound protein bound drugs, then they compete for receptor sites, and that causes more, there's only so many receptor sites, and so then that causes more free drug to be released. So there's always a potential, then you have to watch out for drug toxicity, because you have an increased tendency for that toxicity with two highly bound protein bound drugs looking for receptor sites. And the other thing you have to think about with that is patients that have low albumins for whatever reason, they're either malnourished, or there are other reasons why they don't have enough albumin in their systems, then they don't have enough receptor sites. They can tend to become toxic more readily. One more thing about that is the volume of drug distribution that has to be thought about, and that is the dose and concentration of drugs. Drugs with a large volume of the drug distribution have a longer half-life, and they stay in the body longer. And we'll talk a little more about the half-lives here in a couple of minutes. One more thing, like what I mentioned here, there's an application question here that's on your handout here. What would you expect to see if a severely malnourished patient is taking a moderately high protein-bound drug? A, nothing. B, patient would eventually become toxic. C, patient would be under-medicated. Or D, patient would experience expected results. The answer to that, of course, is B. Malnourished patients, and generally elderly, are prone to also have hyperalbuminemia, even if they're not malnourished. They tend to have less as a given. They are usually very low on blood protein albumin, and this results in fewer protein binding sites. which in turn leads to excess free drug and eventually to drug toxicity. So that's something you need to check on. You need to know your protein binding percentage of all your drugs, and you need to know what your patient's albumin levels are. And you can get that from their chemistry tests. So let's talk a little bit about metabolism. It's the biotransformation of these medications. I'm sorry. On page 6 in your book, and again we're in the 7th edition of this drug book. Sorry, here it is. It gives a very good example of a half-life, because a half-life is actually the time it takes for 1/2 of the drug concentration to be eliminated in the body. And a drug has to go through several half-lives before it is totally out of the body system. And so you need to understand what a half-life is so you can look and see how long it's going to take before that drug is eliminated. And in your book it gives a real good example of if a client took 650 milligrams of aspirin and its half-life is 3 hours. So it takes 3 hours for the first half-life to eliminate 325 milligrams. So then it takes 6 hours for the second half-life to eliminate another half of that, which is 162 milligrams, and so on. So when you finally only have 10 milligrams of aspirin left in the body, it's been like 18 hours have passed. So a short half-life is considered to be 4 to 8 when you're looking at your drug books, and a long one is considered to be 24 hours or longer. And there are drugs with a half-life even longer than that. For example, digoxin, as they give in the book here, is 36 hours. But there are drugs out there, amiodarone for one, has a half-life of days. So it's you have to know these drugs, and so you can be able to think about it. And then you have to remember too, if the patient has some renal issues, it'll take even longer. So then that comes to the excretion, the elimination of the body of these drugs. The elimination primarily takes place in the kidneys, and so that's the reason you have to think about the creatinine clearance and how long that drug is being able to come out, and if the kidneys are working correctly. The liver is the primary site of metabolism, and so that's where the half-life of the drug is started to break down. But patients with both liver and kidney dysfunction, the half-life is longer, so less drug is eliminated. Another little thing to think about is like in DIG or lanoxin, which is a cardiac glycoside inotrope, and it's used for it's an antidysrhythmic. It tries to increase the cardiac output and the force of the contractions by decreasing the heart rate, so that the heart is allowed to slow down to fill and pump a better amount of blood through the body. It's used in heart failure. It's also used in atrial fib and atrial flutter. It's used for sinus tacks. It's also used for cardiogenic shock. On this drug, you always take an apical pulse, because the thing that it's doing is it's lowering the rate so that, like I said, so the heart can fill and get a better force. So you have to do an apical pulse, which is over the heart. You're listening to the heart for 1 minute, and if you hear less than 60 beats, you do not give that medication. You monitor their lights and their BUN and creatinine to see what's going on there. Again, the main way drugs are excreted is through the kidneys. There's also some in the liver, the bile, feces, and lungs when we breathe, saliva, sweat. It's also excreted in breast milk, so you need to pay attention. Protein-bound drugs cannot be filtered. As well, so because they're bigger. So on your next slide there, your pharmacodynamics, we're talking about what that means. That means it's the study of a drug concentration and its effect on the body. So you're looking at the dynamics of that drug concentration on the body. So the primary effect is the desirable effect. There's a secondary effect that may happen, and that may not be desirable, or it may be. It may be a drug that, for example, Benadryl, its primary use is for allergies, but it has a secondary effect that is drowsiness. Well, if you are having sleep issues, you may take that Benadryl at night as a sleeping pill. It's also been prescribed for that, and that is its secondary effect on the CNS depression. Dose response and maximal effect that you're looking at is, for example, if the efficacy of morphine versus a Darvon and the max efficacy of morphine is better, then we would give better pain relief from the morphine as compared to Darvon. So that's looking at how much of a dose does it take to get the maximal effect. Also, we're having to look at onset, peak, and duration of action. So that you're looking at when is the highest, the peak. When you give the drug, you have a minimal effect because you just gave it, so it's just starting. Then you have a peak action when it reaches its highest blood concentration, and then the duration is how long that drug is even effective. So you have to look at that when you're looking at giving a medication, an antibiotic, for example. You want to know where your peak is, and so that you can maintain a nice steady level of delivery of the drug. So you have to be able to time it correctly so that you're giving another drug so that the peak action is coming up in a match as the decline on the other, so that you can maintain a steady level of the medication. Then you also have to look at the receptor sites in there, where these drugs are actually hooking up so that they can actually work. Most receptors are proteins that are found in the cell membranes. That ligand binding domain, which is your receptor theory, is one of your receptor theories. That is a 4 receptor family of types of binding sites that are primarily proteins and enzymes. What that does is, here's the drug that is binding up to activates the receptor, and it binds. Then that activates another step in the puzzle here, is the G protein then gets activated, and it activates the effect. And that effect can either initiate a response or it can block a response depending on. And that's when you look at your agonists and your anti-agonists. Agonists then produce a response. They initiate that response, where an antagonist blocks the response. So when you're looking at it, it can go either way. So then that drug activates a receptor, which activates a protein, G protein, which activates an effect, which is either blocks, which is an antagonist, or an agonist, which produces the response you want. These can either be weak or strong in their response, and it's just on how the little receptor sites fit in to those proteins. So when the receptor is sitting there waiting and the drug comes in, if it fits tightly and it has the right little hinges so that it fits tightly, it's going to have a strong effect on it. Whereas if it's just halfway holding on to it, it'll have a weaker effect. Okay, now drugs can have some non-specific effects that affect multiple sites. And we kind of talked about that a little bit, when I was talking about the Benadryl used for allergies, but yet it is also worked as a sleeper. So non-specific drugs, they, like I said, affect various sites. And one of those drugs that this slide is showing you, uracloline or bethanol, that is a urinary retention drug. It's used for urinary retention or for GERD, those type of things. And it has a cholinergic receptor site on it, and so it will also affect the heart. It decreases the heart rate while you're taking it. It also decreases blood pressure. It increases gastric secretions, so it's kind of speeds that up. It constricts bronchioles. So if you have a person who has asthma or something like that, you got to think about that, because it affects that on the lungs, and it also affects the eyes and constricts the pupils. So you need to be aware of what the cholinergic system and how it affects the different bladder, the heart, the blood vessels, the lungs. They're not real specific, but one that blocks the cholinergic system blocks all of those sites, so they can have side effects that way. Another non-selective drug effect is epinephrine. It's a non-selective drug, and it affects different sites at various receptors. Like when you give epinephrine, you have alpha-1 receptors in the blood vessels, and so your blood vessels then constrict, and you get an increase in blood pressure, which it's given to help that at times. You will have beta-1 receptors within the heart muscle, and epi also is receptive to that, so when it's given, it also affects the heart rate, and you get an increased heart rate. Now, you will get alpha-1 and beta-1 results at the same time. So you will get an increase in blood pressure and an increase in heart rate when you give epinephrine. It also has a beta-2 receptor affinity, and it will relax the bronchioles. And sometimes epi is given for that reason as a bronchodilator. But when you give it as a bronchodilator, you will also get vasopressor effects from it with the increased blood pressure and the increased heart rate, because it is a non-selective drug. So it doesn't act on just one receptor, it goes to all of them. Some of your categories for drug action: you have stimulation, which is the rate of cell activity or gland secretion increasing. You have depression. Depression on your cell activity and the function of the organ are reduced. Then you have replacement, and that's replacing essential body compounds. An example of that is insulin. Pancreas normally makes a good amount of insulin. For some reason your body is not making that, and so we have to give replacement compounds to compensate. Drugs that inhibit or kill organisms are like antibiotics or antivirals. Example of antibiotic, penicillin. It has a half-life of 2 hours. So we need to be aware of that, and you'd have to think about that when we're doing our peaks and troughs. So we have to think about that. And then irritation, that's another way the action will take place. And that is and that's like a laxative, where it mechanically irritates the inner wall of the colon, causing peristalsis and defecation to occur more rapidly than it was going to. Then another thing you need to understand is therapeutic index, or TI. Now this gets a little more confusing, and you can look at your chart here and see if that helps you understand. But therapeutic index is an important thing to know about, because it estimates the margin of safety of a drug. They use a ratio that measures the effective dose in 50% of persons or animals, and compare that to the lethal dose in 50% of animals. And the closer that this ratio is to 1, the greater the danger is for toxicity. So every drug has a therapeutic index. Drugs with lower therapeutic indexes need to be monitored very closely for drug levels. They have a tendency to become toxic very quickly, and they need to have frequent monitoring by lab or otherwise to know where you are with that. Now, drugs with a wide therapeutic index, with a high one, you don't have to do that so much. Those drugs are less likely to cause toxicity. So that's why you need to know it, because you need to pay attention to the drugs with the highest level in the plasma. Okay, let's talk a little bit about peak. Again, that's your highest level in the plasma. If you look back at that table we were looking at, that one that was on table 1.4, I believe. Yeah, table 1.4 in your book. it indicates that rate. It indicates the time it takes for the rate of the absorption to occur. So, because it's monitoring both the time response, onset, and peak times. The trough, though, is the lowest level in the plasma, and it measures the rate the drug is being eliminated. Trough levels are drawn before administering drugs such like as vancomycin, so you kind of know where you are. So you, generally speaking, you always get a peak and trough with vanco, because you're looking for the peak to find out how long it's staying therapeutic in this drug, in this patient, and then the trough to how fast it's being eliminated. So then you can kind of look to how you want to dose this medication. With some drugs, loading dose is given to get a minimum effective concentration in there so that they can start working on the body. An example of that is amiodarone. You'll give a bolus before you start a loading dose of 150 milligrams to get that initial drug in there and working. You do it also with digoxin. You'll give a loading dose of that and then give a smaller dose then over a period of time. Some of the side effects are undesirable from a med, and all drugs have them, so you have to be aware of them, and sometimes they're beneficial, like we talked about with the Benadryl. So we want to be aware beforehand, so you can be watching for them, because some of them can be severe, like anaphylaxis. That is not always what you want to have happen, and then you are coding a patient, so you need to be aware of that. Side effects are also a reason why people are not compliant with their meds. If it has an undesirable side effect, example, a patient who is prescribed niacin, an undesired side effect of that is flushing, a feeling of hot and a red flushing from that medication. Well, there's things you can do to help decrease that from occurring, and making sure the patient know about it beforehand. That is another way to avoid the non-compliance from that medication. There's also the toxic effects, and that's why we do the blood levels on the drugs, such as like DIG, amyloglycosides. Those are some of the things we have to watch and carefully make sure that they're expelled from the body appropriately and we're not getting toxic. And then we also have to look at the pharmacogenetics of the meds, and that's some of the things we learned in the transcultural discussion, because this is an unexpected response because of genetic factors. Example of that is the African Americans and ACE inhibitors. And then tolerance is on there. Isn't that on your list there too? Anyways, that's a decreased response to a med over time, whereas tachyphylaxis is speeding it up. So on your last slide there, your summary, just remember the pharmaceutics of that, they come in either a solid or a liquid form. Oral drugs go through all three of these processes: the pharmaceutics, the pharmacokinetics, and the pharmacodynamics. So oral med will go through either the solid form or the liquid form. It will be broken down into absorption, then distribution, and metabolism, and then excretion. It has to go through all four steps. And then the drug action will have an onset, a peak, and a duration. Depending on receptor sites, where this drug will be held, and enzymes and hormones will react onto those receptors. Just remember that the oral drugs go through all three of these, but injection drugs only go through the last two, the pharmacokinetics and the pharmacodynamics, because they are already in a solution form. You also need to remember, as nurses, you need to avoid toxic effects. So you must know your half-lives, your protein binding percentages, and your normal side effects. What is a normal side effects? Also know your normal therapeutic ranges of these drugs. Use your reference books that we talked about before and help you understand. You'll start getting to where you'll know some of these drugs that you use frequently, but there's a lot of drugs out there and there's new ones coming all the time. So you must use your reference books to keep up to date on them and to understand what you're giving your patient before you give them. You also must use your nursing process. You must assess. That's where you look at it. For example, is this medication absorbable in fat? Well, maybe they shouldn't. They need to, if it's enteric, then no fatty food beforehand. You have to know your signs and symptoms of your toxicity of each drug. You need to know your side effects. An example of like that, it would be atropine, where you get tachycardia. You also get, along with it, you're assuming you're going to get the tachycardia, but you're also going to get dry mouth, constipation, blurred vision. You need to know your peaks and your troughs. Use your references. Now in your nursing interventions in that enteric-coated food, you've got to explain to your patient, no fatty foods because it's going to decrease your absorption. Also be aware of your cultural considerations and the differences in metabolism. And then when you're going to evaluate, did that drug work the way you wanted it to? Was that good drug therapy? This last little slide you have here is your determinants that affect your drug therapy. All drugs are affected by clinical factors. That's your age, weight, your present health disorder, other comorbidities or diseases that are in there, and your drug compliance by your patient. They're all affected by the way they're administered, the form the drug is given, the route it's given, multiple drug therapies, how they interact on each other. That all comes into play when you give a drug. The pharmacokinetics of it, the absorption, the distribution, the metabolism, the half-life of it, and how it's excreted, and is it able to be excreted. That all comes into play. And then your pharmacodynamics, your onset, your peak, your duration of each drug and how that works, your therapeutic range, that therapeutic window when it's actually good, then your side effects and your adverse reactions. Those all come into play anytime you give any drug. So here's your practice question for this one. Number 1, TC has a liver and kidney disease. He is given a medication with a half-life of 30 hours. You expect the duration of this medication to A, increase, B, decrease, C, remain unchanged, D, dissipate. What do you think? Remember, kidney and liver disease, and his half-life is 30. So that would be A. It's going to increase, right, because you're not eliminating it as quickly. So question number 2. In the older adult and those with renal dysfunction, the creatinine clearance is usually A, substantially increased, B, slightly increased, C, decreased, D, in a normal range. So that one would be C. It's decreased. Okay. Good job. Thank you. I hope that helped. I'm sure there was a lot of information there that was a little bit hard to understand. Please don't hesitate if you have questions. I'm sure if you have a question, others are having the same question. So put it on the faculty board or on our way of communicating. If it's something more impersonal in nature, you need to have a question answered, email me and I'll get back with you. And we have one more portion to this week's classes. We have our unit number 4, which we've got quite a bit still to go through. So we will see, there's 2 more. There's unit 4 and unit 5 still to go. So I'll get back with you. Take a break and I'll see you soon. Bye.